also CRRT for CCU patients. Due to most of your patients simply have indication for CRRT due to fluid overload and electrolyte imbalance, and most of them diagnosed with cardiogenic shock, or even sometimes they can have septic shock as well. You can see from this picture that almost 50% of them got died during the hospitalization, and someone might discharge home safely, but 20% of them might encounter or experience renal replacement dependent during hospital discharge. So I would like to present you my overview of CRRT today, which is about the indications and modalities for RRT in cardiac critical care patients. And I will focus on the overview of CRRT, what is it? And due to most of your patients seem to have problem with fluid overload, therefore, normally we pay attention with this patient by using diuretics. And I will focus on another issue, mechanical fluid removal using ultrafibrillation. And I will go a little bit with the guideline. What does the guideline say for the role of CRRT or fluid removal? And the last thing, I may focus a little bit about special conditions that we might use CRRT for our patient. So you already know this pneumatic already, which are easy way to memorize what are the indications for CRRT. I would like to go a little bit to the main guidelines since 2020, which focus on CRRT indication. So RRT should be focused with the emergent condition that treated to the patient condition, especially when the patient has fluid electrolyte or acid disturbance. So previously, I think most of you might initiate RRT when they have single laboratory abnormalities. For example, we went over than 100 or kidney over than 10. But right now, we should focus more about the context. Sometimes I predict in the future that this patient, do they need CRRT or not? So maybe body context might be suitable rather than just use for a single laboratory investigation. And for the RRT modalities, most of them compose of two methods. The first one is intermittent hemodialysis, and the second one is CRRT. I think most of you guys already know about it. But what are the guidelines recommendations? The first one, CRRT and intermittent hemodialysis seem to be complementary for acute kidney injury, but when the patient got hemodynamic unstable, it is recommended to use CRRT rather than intermittent hemodialysis. And another option is for the patient with brain injury or increased intracranial pressure because osmotic shift may cause further brain damage. Therefore, in this case, is it possible maybe we should perform CRRT instead of intermittent hemodialysis? This slide is quite several words, and I'm not sure that if you are not familiar with this one, but I will try to give you a short, the most easy way. So the most often prescribed in critical inpatient, and also this one also prescribed in cardiac critical care as well. The first one is intermittent, which is quite common for hemodynamic stable. But for hemodynamic unstable, we perform CRRT. I will focus about this term later, but it depends on solid clearance, which I will show you later. But the last option for RRT is for remove fluid below. Isolate ultrafiltration means you just remove fluid by hemodialysis machine. But for CRRT requires cuff because its blood flow seems to be lower than hemodialysis. In terms of renal replacement therapy, we should know a little bit about solid clearance method. This graph shows small, middle, and large molecules, which is composed in our body and also accumulated when the patient got renal dysfunction. The role of CRRT is to remove this clearance, or even sometimes we want to remove cytokines or mediator as well. The first thing we call diffusion, which are the main mechanism mechanism for intermittent hemodialysis. You can see that the membrane is semi-permeable membrane. So it can be removed by open dialysis, countercurrent to the patient's blood. For the second technique we call convective therapy. You can see that this technique composed of membrane as well, but we need to create a pressure inside the patient's blood component. So the hydrostatic pressure will increase inside the membrane. Fluid will shift through the membrane and drag some solvent and drag some solute, especially small and middle molecules from the patient blood. The overview of CRRT, the goal of CRRT is to collect electrolyte and acid disturbance, and we need to collect fluid status of the patient and also promote renal function recovery. We don't want to make our patient dependent on CRRT. Why we choose CRRT? Because it is more hemodynamic friendly because it's lower fluid removal than intermittent hemodialysis. Less fluid fluctuation and fluid shift, less intradialytic hypotension, and it's supposed to cause less renal injury and may promote renal function recovery better than intermittent hemodialysis. However, in terms of survival, it's still controversial. This is the scheme of CRRT. You can see that this is the patient blood come through the vascular access, go through the membrane and return to the patient circulation. The yellow one seems to be similar to our blood, or even sometimes it looks like our urine, which is yellow color, represented by yellow color. And if you want to perform intermittent or dialysis or diffusion technique, we should turn dialysis. For the convection therapy, we should focus on this fluid, which is replacement fluid, where it can be integrated to the patient but via pre-membrane and post-membrane. In terms of fluid regulation, we need to focus on two things. The first one is the blood flow rate open form CRRT, and the second thing, we need to focus on dose of CRRT as well if you want to remove the solute out, similar to renal function. And in terms of fluid administration during CRRT, as I already showed you in the scheme, there are two fluid components. The first one is convective therapy, which is re-dilution and replacement fluid, and post-dilution is represented by a green color here. And for the diffusion technique, it is dialysis, which is local one. In terms of fluid removal, the yellow one here can be just only remove fluid out alone, which is isolate GF or scarf. In terms of integration with solute clearance, sometimes we need to perform intermittent hemodialysis or CRRT. When we want to perform CRRT, we should check the patient. Is there hemodynamic status issue or not? How severity of our patient is? How much of the fluid water inside the patient? And we should look at, are there any phase? Is there a phase of resuscitation proper enough for removal? Or sometimes in the case that you think cytokine storming to the patient, maybe we have to focus to remove cytokine as well. CRRT prescription is similar to medication. We need to focus on which drug or which modality is appropriate to the patient. The second thing, what is an appropriate time for initiating CRRT, and how much dosage that we need to perform in this patient, and how to monitor, and the last one, when is appropriate time to discontinuation. Several studies has been investigated several years, but right now there are some meta-analysis that I showed you here that comparing between CRRT and intermittent RT that shows similar survival between these two techniques. Therefore, it depends on your patients. Are there any hemodynamic unstable or not, or acute brain injury? Maybe we have to focus to use CRRT instead of intermittent hemodialysis. But in the case that do not have problem with hemodynamic instability, maybe intermittent hemodialysis seems to be better option. In regards to initiation time, you can see from this picture that both 28-day and 90-day mortalities looks similar when comparing between early intervention and late intervention. However, I would like to show you that in cases with emergency situation, for example, I'm show you exclusion criteria from ideal ICU and start care study. You can see that when the patient has emergency indication for CRRT, we should not delay CRRT. For example, in the cases that have hyperkalemia or severe metabolic acidosis, or even the patient has fluid overload too much, that maybe sometimes we have difficult situation when setting the ventilator. It is time to initiate CRRT immediately. Don't delay this case. And what about appropriate dosage for CRRT? You can see that in the beginning of 2000s, it seemed to be favor for higher dose of CRRT. However, after that, especially at the late of 20th century, you can see, 20 decade, 30 something, around 2008 and 2009, you can see that the evidence showed here there are not different between dosage of CRRT when you perform higher dose comparing to standard dose. Right now, clinical recommend us to perform CRRT with a dosage of 20 to 25 ml per kilo per hour. However, sometimes the nursing counteract with the machine or patient have to be sent to the OR for operation or go to imaging. Therefore, the prescription should be around 25 to 30 ml per kilo per hour. This is the example to calculate the dose of CRRT. If the patient has 60 kilograms, therefore the dose should be around 1.5 to 1.8 liters per hour. And not just only the dose for each case, but you have to look at the patient condition as well. For example, if the patient just has cardiorenal syndrome, it means most of the cases has stable hemodynamic, therefore it can be removed a little bit faster. If the patient got septic shock as well, sometimes we have to leave the patient accumulate in the patient instead of removal. When vasopressor has been tapered off, it's time to remove the fluid. And this is a recommendation that if you perform intermittent hemodialysis, fluid should be removed over than 13 ml per kilo per hour. For the CRRT, it should be over than 1 to 2 ml per kilo per hour. Because we have to focus on vascular refilling rate. That should be much higher than fluid removal. Or even sometimes due to critical patient may got problem with intravascular depletion, or even sometimes they might have cardiogenic shock, dysfunction, or hypoalbuminemia. This one can cause the patient easier to have hypotension during CRRT as well. For CRRT, special issue that we need to focus on is about care and the membrane clotting. Therefore, we have to give the patient anticoagulation as well. And in terms of discontinuation, when it's an appropriate time, if renal function recovery, it means no need to perform RT anymore. Usually, we should look for urine output if it exceeds over than 500 ml per day. Or in the case with diuretic, the cutoff should be about 2 liters. I think cardiorenal syndrome seems to be one of your most problems as well, because we have both diuretic and ultrafiltration, and we discussed about ultrafiltration a little bit, but you can see that diuretic is also the treatment, but it can cause the patient problem as well, especially electrolyte imbalance or even renal dysfunction. Another option to remove just only fluid, but solute cannot be removed by this technique. This is the example of machine, where it's smaller and less complicated less sophisticated than CRRT. It can use just only single lumen and can be used peripheral line to remove fluid as well. This shows the evidence that this kind of machine can remove fluid and reduce re-hospitalization of ongoing study. But from Khariz study, you can see that there is a little bit higher serum creatinine during treatment. However, at 30 days and 60 days, renal function seems to be better than using diuretics. Okay. And for the next two studies, similar benefit in terms of re-hospitalization. So I would like to summarize the role of ultrafiltration versus diuretic. You can see that the most beneficial is re-hospitalization from three main landmark studies. But one study shows that serum creatinine a little bit higher when compared to diuretic. But you can see that their population looks different from other studies. They use ultrafiltration in cardiovascular syndrome as a rescue therapy. Therefore, and they turn ultrafiltration rate a little bit higher than other studies. This might explain why patients got renal dysfunction during ultrafiltration. However, for cardiovascular syndrome, sometimes during hospitalization, when the guidelines say that when we give patient diuretic, sometimes we have to have patient with a little bit change, a little bit increase in serum creatinine or even concentration, where outcome might be better than those patients who do not have these events. I would like to show you what are the adverse effects of ultrafiltration. Sorry that there are many details in this slide, but I will highlight here that most of the adverse effects seem to be similar to CRRT or even intermittent hemodialysis. For example, bleeding, catheter infection, or clotting, which are quite common for extracorporeal surgery, right? And sometimes we have encountered with cause and lack of experience of these procedures. And I would like to show you this slide as well. What are the exclusions? Because someone might wonder how different between ultrafiltration alone and CRRT. You can see that most of the indication for ultrafiltration exclude those patients with cardiogenic shock or hemodynamic instability, or even in the case that serum creatinine over than 3 or 3.5, which ultrafiltration can be done just in case with heart failure without hemodynamic compromise or normal renal function. When the patient got renal dysfunction or hemodynamic unstable, maybe it's time to perform CRRT instead. What are the guidelines saying? Example for ultrafiltration is recommended regularly. It's not unresponsive to diuretic. Similar to HA, but HA also make a recommendation that we need to investigate further what are the indication, patient selection, what is appropriate hospitalization, or even how to prevent complication. And another guideline is from kidney doctors. They also recommend mechanical fluid removal in cases where diuretic resistance occurs. Another option for CRRT, I think everyone also has experience about ECMO, right? To improve oxygenation, improve cardiac output. But ECMO usually cause AKIs. So, however, CRRT seems to be one option for this population as well, but we right now is complete evidence to which strategy are the most are the best way when performed. These are the method to combine CRRT with ECMO. Sorry, I have no time left, but I will show you the example that CRRT can be integrated to ECMO, especially I think this is recommended to connect CRRT into segment of ECMO. You can use just with the membrane or integrate with the membrane, with the CRRT machine as well. However, you need to check that can your CRRT accept high pressure alarm or not. Please discuss with your distributor because ECMO pressure might cause a high pressure alarm if your CRRT is not updated to accept high pressure. Okay, and another option for CRRT due to cardiogenic shock or even patient underperform ECMO that have cytokine storm. Right now we have several membranes that can remove cytokine as well. This is the example. Okay, I would like to conclude my presentation today that CRRT is quite common therapy for CC patients, especially in those patients with fluid overload or they have solid problem during toxic. I already mentioned about what are the indication, modalities, dosing, how to monitor, and when is appropriate time to discontinue CRRT. And the last one I already mentioned about CRRT in special conditions, especially in those patients perform ECMO and also cytokine removal. Thank you very much for your attention.
Thank you.